This conference will now be recorded.
Welcome in, everybody. On today's lecture, we're going to be talking about OB/GYN, emergencies, normal, labor and delivery, and then also caring for that neonate once it is delivered. So first, let's look at physiological changes that we're going to see with our pregnant female patient. Now, a lot of things are going to be changing and evolving when that female is actually creating life. They have to compensate in ways that the normal adult is not going to have those changes. So first, let's look at the uterus. So this is where that fetus is actually going to be growing. And within the fetus, this is going to provide warmth and then also protection. But as that fetus actually grows bigger, that uterus wall is actually going to become thinner, and then that protection level is actually going to go down. So much more vulnerable to injury as that uterus grows larger. The normal pregnancy is going to last about 9 months, and it's going to be broken up into 3 trimesters. So that first trimester, we're not going to see a lot of physical changes with that female patient, but that fetus is being formed, and this is where the most susceptible as far as injury and or death from spontaneous abortion is actually going to occur with that fetus. After that 3rd month, so this is going to be entering into the 2nd trimester, this is where that uterus grows rapidly. We see a lot of physical changes. That female is going to start to display physical changes and being able to identify that that individual is actually pregnant. So within that amniotic sac, that is the main protection and warmth within that uterus section. And again, once that amniotic sac is broken, then they're going to lose a substantial amount of body heat and then also protection too. So that's going to enter into the actual stages of delivery, which we'll talk about in a few slides. So then with physiological changes as far as vital signs, blood volume, cardiac output, these are the big changes that we're going to see, especially once that female enters that 2nd and that 3rd trimester within that 9-month time period. So we can see the cardiac output is substantial change where we're looking at 40 to 50% increase. Also, diastolic blood pressure, this is another big one. So our normal values are going to be 120/80 for our adult patient, but we're going to see that diastolic rise about 20%. So we might see normal blood pressure values range right around 130 to over 100 when we are dealing with that patient. And then we can see all of the other parameters when we are dealing with changes at that level. So let's talk about normal labor and delivery. So this is something that a lot of EMS providers get squeamish about because we don't actually encounter it very often. It is a pretty chaotic scene, but remember, individuals have been given birth for thousands of years. So this isn't nothing new by any means. Oftentimes, as far as what our role is going to be, is just a facilitator and help guiding that baby out of the birth canal. So first stage, we're going to see regular contractions, thinning and gradual dilation of that cervix, and it ends when that cervix is actually fully dilated, in which case we are going to enter into our 2nd stage. So this is when that baby actually enters the birth canal until the baby is born. So once that baby is completely out, then the 2nd stage is completed, in which case we enter the 3rd stage. That is when the afterbirth is actually going to be delivered. So that is the placenta. The placenta preferably is still going to be attached to the baby after that 2nd stage. And then we can go ahead and sever that umbilical cord, which we'll talk about in a couple of slides here. So we can see first stage, again, that cervix is going to start to relax, it's going to thin, and it's going to dilate in preparation for that baby to enter that birth canal and then fully be delivered. So this is the preferential way how that baby is actually going to be sitting inside that uterus with the head down, resting against the cervix, and getting ready for that cervix to go ahead and dilate and then push out. Where we run into substantial issues is if any other body part is presenting against that cervix, and then we're going to have a breech delivery, which we'll talk about once we start talking about emergencies within OB. Then we can see the second stage, in which that baby is actually going through that birth canal. See, the head is delivered first, and then what we have to do is facilitate those shoulders to make sure that they go through the cervix and that pubis bone properly. And then that last stage is going to be that placenta actually separating from the uterine wall. We never want to tug on that umbilical cord when we do get to that third stage. That excuse me, placenta is going to go ahead and separate all by itself, and it's going to gradually pass, usually 10 to 15 minutes, if that, as far as the placenta separating and then leaving the uterus. So with labor pains, once that female starts to enter that first stage of delivery, we're going to start to see contraction time and then also contraction interval, or also referred to as duration and frequency. So the duration is going to be time from the beginning of a contraction to when the uterine relaxes. And then the contraction interval, or the frequency, is going to be the time from one contraction to the beginning of the next contraction. So again, this is going to be normal stages. Oftentimes that contraction time is going to start relatively small. The contraction interval is going to be relatively long, but that contraction time is going to start to escalate, and that contraction frequency is going to start to be smaller and smaller once that individual is getting ready to go into that second stage of delivery. So when the contraction lasts between 30 seconds and 1 minute, and are about 2 to 3 minutes apart, this is an indication that that baby is coming. Delivery is imminent, so you got to be prepared as an EMS provider to go ahead and facilitate that delivery of that baby. When we are assessing the woman in labor, what we want to do is first get our demographic information. When we are doing this, what we're starting to do is build that patient rapport between us and our patient. So then we can refer to them as their name, and then start to get some of our general history and patient assessment information. And that way we can start to know whether that delivery is imminent and what we should do as far as preparation. We want to discuss how many pregnancies she's had, how many births she's had, and then also if there's been any complications in regards to those births that she's had. Now, if it is her first pregnancy, the average time from when she first starts developing those contractions is going to be about 16 to 17 hours before we actually enter that second stage of labor, depending on our patient. But again, the majority of these patients are going to be in that first stage in between about 16 to 17 hours. We always want to find out whether she's seen her doctor regularly for this, and then also taking prenatal vitamins. We're going to discuss some of the implications as far as being prepared to give neonatal resuscitation, and that's a big one. Ask when they started, ask how often. Hopefully the significant other within this relationship is keeping track of that frequency and that duration at that point, and they can go ahead and give you that information, and then you can start to see the trends within that frequency and that duration. Ask too whether that bag of waters has been broken. So that is oftentimes one of the first stages within that first stage of delivery, is that water being broken. And then also what they refer to as the bloody show, in which that plug will actually be discharged, and you see a lot of that fluid being drained from that female patient. Next, we're going to ask if they have the urge to push or have a bowel movement. So this is an imminent sign or symptom in which that baby is actually being delivered. So if that female is asking to go to the bathroom and have a bowel movement, do not allow her to do that, because that's an indication that that baby is actually ready to come out. So there's been plenty of cases where babies have actually been delivered into a toilet because of this specific case. Then examine for crowning and be cognizant of that patient's privacy at this point. It's always best as far as using your resources. So if you have a female individual on your crew, oftentimes that female is going to feel a little bit more comfortable if a female is examining for crowning. If you don't have a female available on your crew, then again, develop that patient rapport. Whoever's doing the primary patient assessment should be the one examining for crowning. Feel for uterine contractions, so place your hand on their stomach, feel for any contractions, and that way you can actually examine and get all the information as far as that frequency and that duration of those contractions. And then again, take vitals. So think about this, how are those vitals going to be affected? Everything is going to be elevated at this point. Heart rate's going to be increased based on pain, and then also getting that individual prepared to go ahead and give that birth. Blood pressure is also going to be elevated, but it could be low depending on the positioning of that patient and how much weight that baby is actually presenting on the vena cava. And we're going to talk about that too with supine hypotensive syndrome. So when we are doing our assessment, these are going to be big findings within our assessment and our history taking that should indicate us that we might be providing neonatal resuscitation. So if there is no prior prenatal care, that individual is not taking any type of prenatal vitamins, this is a big indication that that individual is not going to be fully developed, specifically the cardiovascular and pulmonary system. And there's a significant amount of stress that's being put on that fetus when it is being delivered. So if they're not receiving any prenatal care, that's a gold stamp that you have to be ready for providing resuscitation efforts. Any type of premature delivery, oftentimes premature is going to be any time in between 28 weeks, in which case that baby is not going to be fully developed. Again, pulmonary system, cardiovascular system is going to be greatly compromised at that point. Any type of labor-induced trauma or medical condition, especially when we're dealing with motor vehicle accidents and that female is actually driving, because that abdominal area is going to strike the steering wheel and that can actually induce labor at that point. Multiple births, so twins, triplets, they do not have the capacity, the blood supply, or the nutrients to actually be fully developed. That's why oftentimes when we see multiple births is those neonates that are being delivered are often really small. So if you do have multiple births and hopefully that individual knows that they have twins or triplets or what have you, then be prepared for that. Any history of problems with pregnancy, be aware too of any individuals who have bleeding disorders. So hemophilia, anything like that can cause significant blood loss. And then as a result, that mother could go into cardiac arrest or also that neonate could go into cardiac arrest. Labor induced by drug use. With this, anything that mother takes, that neonate is actually going to absorb themselves. So be prepared that you might have to go through your drug overdose protocol when you are dealing with a neonate, even though the mother actually took those drugs. When you see meconium staining, that is severe stress placed by that baby. So that is the first bowel movement that's actually going to occur inside of the uterus. It's preferred that that individual has their first bowel movement once they are actually delivered after that second stage of delivery. So when they do have that meconium inside the uterus, oftentimes what happens is that individual will actually aspirate some of that meconium, and that can lead to significant infection and then also respiratory issues with that. So this is what that meconium staining is going to look like. Again, this is stool or a bowel movement, and what we're concerned about is airway compromise at that point with that individual actually aspirating that meconium. With this, as far as treatments go, we might have to be a little bit more aggressive when we are suctioning that patient. Now, normal delivery, once that baby is delivered, that airway is good. Infant's crying, breathing properly. We don't have to suction that airway. What they used to teach us is once that head was delivered, we're going to go ahead and suction the nose and the mouth. We do not do that anymore. What we found out is oftentimes we are actually overly aggressively treating that airway with suction techniques. And as a result, that infant was actually vasovagal down. So remember from our pathophysiology lectures, in which when we vasovagal down, that heart rate and that blood pressure drop pretty significantly. So again, only suction as needed. With meconium staining, be prepared to suction a little bit more aggressively. So now let's talk about prepping, treatments, interventions that we're going to go ahead and do for our normal delivery status. Control that scene. Again, it's going to be chaotic, especially if you have multiple family members there. Oftentimes, the significant other is going to be the one who's most chaotic at that point. Don your PPE. Be overly aggressive with this. Have multiple gloves situated. Have a gown, because these can become pretty messy scenes. And make sure that you have as much sanitary precautions as possible to protect that fetus. Because that fetus has not been introduced to any microorganisms yet, again, try and be prepared for that. Place that patient on a bed or a floor, elevate the buttocks so that you have better control of that fetus actually coming out. And again, place some sanitary napkins below that cervix area so that you can be a little bit more controlled with scene safety and PPE. Remove any clothing that's going to obstruct that view, and again, be cognizant of that female's privacy. So whether you're using sheets or making sure that you're controlling the scene by eliminating people who might be on that scene that don't need to see what's actually being done. Position, preferably the significant other up by the mother's head so that they can provide that comfort care for that individual. Get the OB kit out. Get the OB kit ready too. So make sure that you have the tools and equipment necessary to go ahead and provide delivery. And we're going to take a deeper dive into that OB kit once we meet for our lab session. Also have suction readily available as well. And then also your airway interventions. Make that environment as warm as possible. So if you're in the back of an ambulance, go ahead and crank that heat up. If you're in somebody's house, ask that individual to turn up their heat, whoever can actually do that. Once that baby is delivered, what we want to do is aggressively rewarm that baby. So wipe off all of that residue. And then what we can do is actually immediately place that fetus up on the mother's chest, because that body heat from that mother will actually provide quite a bit of warmth for that baby. Again, dry them off. Be cognizant of their skin, because their skin is not as tough as the adults or the pediatrics that we're going to be dealing with. And then make sure that you go ahead and place a neonatal cap on that infant's head, because they lose a substantial amount of body heat out of the top of their head. That's where we want to do this. And then also wrap that baby nice and tight to provide that warmth. So when we're assisting in that normal delivery, we're going to dive a little bit deeper into what I was just saying. Provide that comfort care. Then once that baby starts crowning, you want to be prepared for any type of explosive delivery. So you're going to place your gloved hands gently as that head appears. Be very cognizant of that soft fontanelle when you are placing your gloved hand on that patient's head. So you're going to provide just gentle pressure once that baby's head starts to be delivered. Now, if that amniotic sac is not broken, it is difficult for that baby to actually be delivered. So if that amniotic sac is still in play, then you're going to go ahead and place your fingers and then gently tear that amniotic sac. Be prepared for that fluid that's going to be coming out. Once that head is delivered, go ahead and check for an umbilical cord, making sure that it is not wrapped around their neck. If it is wrapped around their neck, then if you have enough leeway with that umbilical cord, make sure that you try and guide it over that baby's head. If not, you might have to go through a few more steps, which we'll talk about later on in this slide. Then we're going to help deliver the shoulders. So oftentimes what we're going to have to do is go ahead and place that infant's head into a sideways position, and then we can go ahead and assist delivery with the shoulders. So we gently guide down on that infant's head and drop that top shoulder down first, and then we're going to guide that infant up, and then we're going to deliver the bottom shoulder. So we always want to try and deliver the top shoulder first, so you have a little bit more room. When we deliver the bottom shoulder first, this is oftentimes what will happen, in which that neonate actually gets stuck inside that birth canal. Always support that baby the entire way through that birth. Once those shoulders are delivered, oftentimes what we'll see is an immediate delivery, in which they are very slippery. So we want to make sure that we don't actually drop that infant or that neonate. Once that baby is completely delivered, assess the airway, suction as needed. Note that exact time of that birth at that point too. So we're going to go ahead and watch a video of the normal delivery process. Or we're not. Sorry about that, guys. I didn't realize that that got taken off. So when we meet for lab, then we'll go ahead and go through a normal delivery video. So caring for the neonate, once that individual is actually delivered, we're going to go ahead and give them an APGAR score. So we're going to do this 1 minute after the birth and then 5 minutes after the birth. So each letter within the mnemonic of APGAR is scored from 0 to 2. Make sure that you are keeping that baby as warm as possible, and then be prepared to go ahead and cut that umbilical cord. So within your OB kit, you have 2 clamps. You're going to clamp one at 10 inches, then clamp another 7 inches, and both of these are going to be away from the baby. So again, 7 inches away from the baby, 10 inches away from the baby, and then palpate that umbilical cord in between those 2 clamps and make sure that it stops perfusing at that point. Once you stop feeling a palpable pulse within that umbilical cord, then you can go ahead and cut that umbilical cord. Within that OB kit, either scissors or a scalpel is going to be included. So go ahead and sever that, or if that significant other is still there, go ahead and ask them if they want to go ahead and cut that umbilical cord. Now, if you open up your OB kit and all you have is a scalpel, I would recommend that you go ahead and cut that umbilical cord just for safety precautions. So this is our APGAR scoring system. Again, each letter within APGAR is going to have a mnemonic. So A is going to be for activity, P is going to be for pulse, G grimace, A appearance, R is going to be respiration. And we can see moving to the right side of that scale how each point reflects upon the health of that baby. Now, oftentimes within that first minute, that baby is going to be blue, gray, multiple different colors. Once they start crying and getting oxygen in their system, they pink up rather quickly. So after that 5 minutes, what we're looking for is a good trend upwards, in which case we should have a significantly higher score within that APGAR scoring system. So when we do deliver that baby and they are not breathing and they don't have a palpable pulse, we have to provide neonatal resuscitation, in which case this is the steps that we're going to provide. So first, provide warmth, assess the baby's airway. Oftentimes with warmth, drying them off, we can actually trigger that individual to start spontaneously breathing on their own. Suction as needed with a bulb syringe. We should not be using a VVAC or any type of electrical suction device at this point. Establish that respiratory rate, provide stimulation as needed. Bottom of the feet is where they're going to provide the most stimulation. If they are not breathing or not breathing adequately, we're going to start ventilating them, and this is going to be rapid ventilations, not like we ventilate for our pediatric or our adult patient, but this is basically going to be one breath every 6 seconds. Assess the heart rate. Any heart rate less than 100, begin ventilations. If less than 60, make sure that we begin our chest compressions. This is our hierarchy as far as interventions that we are going to be performing with that neonate. Basics, working our way down to our more advanced treatments, such as our drugs and our chest compressions. Again, with normal delivery status, by keeping them warm, a little bit of oxygen, such as blow-by oxygen, and then maybe a couple of ventilations with a bag valve mask, oftentimes we're able to trigger that internal factor within that neonate, and they can start crying and breathing on their own pretty substantially. So with any OB call, remember you have two patients. You have the neonate, and then you also have the mother. So once that baby is delivered, and again, you have resources available to go ahead and care for that neonate, make sure that you have a few resources who are also caring for the mother at that point. So at this point, that umbilical cord is cut, and we're just waiting for that placenta to go ahead and be delivered on its own. Make sure that we're controlling any substantial vaginal bleeding. Now there is going to be some, but if it's heavy flow and it's not stopping, then we got to go ahead and start providing interventions for that bleeding. Place the sanitary napkin over that vaginal opening and then start providing direct pressure if we are seeing substantial flow within that blood. We also going to have that mother lower her legs and then also keep them together. And again, that's going to provide a little bit better direct pressure for controlling that bleeding. If that bleeding continues, we can provide a uterine massage so that it's going to contract and then also constrict those blood vessels, and that's going to help stop the bleeding. Another thing that we can do is encourage that mother to start nursing. So once that baby actually starts eating and feeding, the mother will actually release hormones within their system, and those hormones will actually help stop that bleeding at that point. And then provide comfort care to that mother and start obtaining vital signs on her as well. This is an example of that uterine massage. Be careful with this and be aware that you are going to cause some substantial pain when you are doing this as well. But pain is better than death, and if they are bleeding substantially, then you're going to have to go ahead and do that. You can see, take a couple of fingers, and it's going to be direct pressure on that abdomen, on that uterus, and then upward pressure of that too. So that basically formulates our normal delivery status, which we should see on probably about 90% of our OB calls within our EMS career. What we get concerned about is any type of complications. Now, I mentioned this earlier as far as breech presentation. If anything is presenting out of the cervix opening besides the head, this is going to be marked as a breech presentation. And for us as EMS providers, we are not fully trained as far as how to position the mother in the best capacity in order to help facilitate that. So this is going to be an immediate load and go. When you do have these presentations, one thing that you do want to do as far as interventions is keep that limb or whatever presenting part as warm as possible, and then also encourage that mother not to push at this point. If we have a prolapsed umbilical cord, this is going to be when that umbilical cord is actually presenting first. And oftentimes what will happen is you're going to have the umbilical cord and it's going to start to protrude out of that cervical opening, and then that head is going to be right behind it. So oftentimes what will happen is that baby's head will actually compress that umbilical cord and cut off the circulation to that umbilical cord from that baby's way to their head. So if you do see this and you encounter this, what you want to do is place your gloved hand inside that cervical opening and then relieve that pressure off of that baby's head to the umbilical cord. So you're going to place your gloved fingers in and then gently push back on that baby's head so that they are not compressing that umbilical cord. For multiple births, be ready. Hopefully you have multiple OB kits readily available, but think of it as a normal delivery, only you're dealing with it multiple times. So you're going to deliver one, have your resources readily available to care for that neonate, and then be ready to go ahead and provide facilitation of that delivery for that second one. Our premature infant, any newborn weighing less than 5.5 pounds or before that 37th week, I think I made a mistake earlier and said the 28th week, but it's anything before the 37th week. And again, they are not going to be fully developed at that point, especially their pulmonary and cardiovascular system. So these are a couple of different breech presentations that we could see. The frank breech is going to be the buttocks is presenting, and we can see that that individual is really lodged within that pubic area. Same thing with that complete breech. And then when we see a footing breech, that's where that foot is actually protruding. Oftentimes, all three of these breeches, we're going to need more definitive care within the OB unit, in which they're going to have to do a C-section on that individual in order to get that baby out. Here, an example of that prolapsed umbilical cord. So you can see where that head is going to start to guide down that birth canal, and then they're going to go ahead and decompress that umbilical cord, and they're cutting off circulation in that blood volume that's actually being pushed to that baby at that point. So with that, that baby is actually going to start suffocating internally because they do not have any type of blood supply going to them at that point. Then we can see differentiation between identical twins and fraternal twins. So hopefully mom knows this when you are doing that patient assessment and that patient history. So with identical twins, once those two are actually delivered, you're only going to have to be ready for 1 placenta. For fraternal twins, we got to be prepared for 2 placenta at that point. Here's an example of a neonate that's actually less than 5.5 pounds. So this is going to be an early delivery. And again, we have to be aggressive on our treatments because oftentimes they need additional stimuli, they need additional interventions for them to actually start breathing and cooperating on their own. So emergencies in pregnancy. When we have a placenta previa, this is going to be placenta that's formed in an abnormal location, and it will not allow for normal delivery. The major point that we're going to be concerned about is if that placenta is actually over the cervical opening. Now, oftentimes, if they are receiving prenatal care, this is going to be identified. Oftentimes, these individuals will have a scheduled C-section ready to go. Abruptio placenta. So if the placenta separates from that uterine wall prior to that second stage of delivery, again, they are not getting the full blood and nutrients needed. And again, hopefully we're in a timetable that we can actually get that individual to the hospital prior to that baby actually being delivered. What we're going to see as far as signs and symptoms with that abruptio placenta is a heavy amount of bleeding, and then oftentimes the mother will complain of a heavy amount of abdominal pain as well. When we have ectopic pregnancies, so this is going to be implantation of the fertilized egg, and it's not going to be in the body of the uterus. Where we see the biggest complications and the biggest emergency is going to be when that implantation is actually located in the fallopian tubes, and that can cause some pretty significant acute emergencies and then also chronic emergencies. Oftentimes what will happen is if they do have that develop within the fallopian tubes, the mother oftentimes will not be able to actually get pregnant again. What we see with ectopic pregnancies is, again, severe abdominal pain, some pretty substantial bleeding. These signs and symptoms are going to be very early if that mother detects that they are pregnant. Eclampsia, so this is going to be a complication of pregnancy that produces seizures and coma, and how this is developed is from preeclampsia. So this is going to be from significant hypertension, from a substantial amount of increased fluid within that female patient. So again, a lot of information covered here. Our OB calls are pretty few and far between. And when we do get those OB calls, oftentimes what we're going to do is provide just facilitation for a normal delivery and or simply transport that individual to the hospital. Oftentimes they're going to be able to make it and then actually provide that delivery within the OB unit. Thanks, everybody.